Hello students, my name is Dr. Astha Jain. I'm a consultant pediatrician and neonatologist. Today we are discussing a very important topic of neonatology. It's empiric antibiotic therapy in neonatal sepsis. To understand antibiotic therapy in neonatal sepsis, you will have to understand what neonatal sepsis actually is. Now, when you think of the term sepsis, the word that comes to your head is infection. Okay, so this is basically neonatal infection, but it is systemic and it is not just a normal infection, it is a life threatening condition. Okay, so it's a life threatening condition due to a systemic infection. That means all or most of your organ systems are involved. Life threatening condition due to systemic infection in neonates. Now, what are the common organisms that cause neonatal sepsis? The first one and the most common being group B streptococci, Staphylococcus aureus, E. coli, Klebsiella, Pseudomonas, but it is not just limited to that. There may be other infections like Acinetobacter, right? But these are quite common, Klebsiella being a very common of neonatal sepsis. Gram-positive organisms like group B streptococci, Staph aureus are also very common. Now, how do you classify neonatal sepsis? It is classified on the basis of the hours that have passed since the baby is born. So we take 72 hours as a cutoff, right? Any sepsis or any infection signs that you see in a baby before 72 hours, it's called early onset sepsis, and in a baby after 72 hours of birth, it is called as late onset sepsis. Understood? Please write this down. Early onset sepsis and late onset sepsis, it is extremely important. And why do I say that it is extremely important? Because our treatment also varies on the basis of that. Now, what is the need for empiric therapy? Okay, before this, I want to tell you what neonatal sepsis actually causes in a baby. So, what are the symptoms? Suppose if a baby comes to you, how will you find out that this baby may be septic or not? Okay, now in babies, unlike adults, the symptoms are not going to be so definite, so clear. And why is that? Because they have immature immune systems. They do not have the ability to contain infections like us. Whenever we have an infection, what is the first sign that we see? It's fever. Now, since the immunity itself is not built up, they do not have fever. They may or may not have, but most of the cases will not present with fever. So you will have to catch subtle signs of sepsis. What are these subtle signs that we are talking of? Number one, poor feeding. If your newborn refuses to feed, if there is extreme lethargy, if the newborn has become cold, if there are spots or marks on baby's skin, all of this contains neonatal sepsis. So when a mother asks you, ki doctor, mujhe kaise pata chalega? How will I find out if my baby has infection? You will tell her that please watch for these red flag signs. Number one, if your baby is not feeding, if your baby is lethargic, if your baby is always sleeping, is not active at all. And also one of the red flag signs, if your baby is not passing urine, if your baby appears cold, pale, clammy, then the baby may be septic. Okay. Now, what is the need for empiric therapy? Why do you want to start antibiotics before you've proven that this baby has sepsis? Because neonatal sepsis is relentless. It does not give you time. The baby deteriorates so fast and it is life-threatening. I have seen babies deteriorating in a couple of hours and even dying because antibiotics were not started at the right time. And that is why these empiric antibiotics are important. In a baby where you're suspecting sepsis, what is the ideal protocol? You admit this baby. Okay, this baby is never seen on an OPD basis. If there is a neonate and you're suspecting sepsis, you admit this baby, you send a few routine investigations, which we will be talking about earlier. But blood culture is the standard and the gold standard investigation that you send. But how long does it take for a blood culture to come? it takes around 48 to 72 hours. Can we wait till then? No, because your baby will deteriorate till that time. Hence, the need for starting empiric antibiotic therapy. So if you delay in treatment, it increases mortality. How will you decide what antibiotics to begin? Age of onset. When has the infection started to occur? Was it within the 72 hours of birth? Was it after it? Local microbial patterns, very important. Now, the antibiotics that I may be starting in my NICU are different from the antibiotics a neonatologist is starting in Kerala. Okay, for example, or some other ICU. They're not going to be the same. Why? Because the flora in every NICU is different. What do I mean by flora? Flora is the microbial pattern of that particular ICU. And how will you find out what are the organisms that are growing in this ICU? So every once in few days, we have the microbiology team coming in with swabs, and they collect swabs from the warmer, from the bedside tables. They collect swabs from where the fluid is being made for the babies. They even collect swabs from the healthcare professionals' hands. So we also give our hand swabs, and then they test it. They test what organism is growing in this particular NICU, and they give us a full detailed report of the organisms, and then we alter our medications accordingly. Okay, so we then start the empiric antibiotics, which would be useful against that particular organism that is growing in that particular NICU. Do you understand? Also, risk factors in a particular baby are very important. That's why you ask for a detailed history. Okay, if there has been a history of maternal infections, if there has been a history of premature rupture of membranes, these babies are more prone to develop sepsis, right? Now, first line empiric antibiotics. What are the first line antibiotics that you begin? Early onset. Now, I did not cover it that time. Early onset sepsis is which happens within 72 hours of birth. So from where do you think the infection is coming? It comes either from the maternal womb, or it comes intrapartum, antepartum or intrapartum. Okay, so antepartum meaning if the mother had fever during pregnancy towards the last few days, if the mother had chorioamnionitis, that is infection of the amniotic fluid or the membranes inside, if the mother had premature rupture of membranes, if the mother has had leaking per vaginum for around 6 hours or more, then there is a chance that this baby may be infected. And hence we as pediatricians have to ask the obstetrician about proper maternal history. Okay. When I say intrapartum infections, what do you think is happening? If the baby is being delivered under unsterile conditions, when you deliver the baby, the labor room wasn't clean, or the conditions have been unsterile, then the baby may get infection even while passing through the vaginal canal. Postpartum is after the baby has been admitted. Okay, so in the first 3 days, if the baby's been admitted to the NICU, the infection from there, if the baby's had any IV lines, any tubes and dressings that have been used for the baby, if that can cause infections. Okay, and after 72 hours, if the baby starts to show symptoms, which we've already discussed, then it's called late onset. Now coming on to the treatment. We normally start with a gram positive and a gram negative cover, the most basic medications. So ampicillin, which is a beta-lactam antibiotic, that is started. Along with that, an aminoglycoside, which mostly covers gram-negative organisms. So you start a combination of ampicillin and gentamicin. Late onset, if the infection has occurred later, then you start vancomycin. Or if the baby is in an ICU, the infection seems severe. If there is brain involvement, you can start cefotaxime or meropenem. Ceftriaxone is normally not started in neonates. You start cefotaxime. Both of them have the ability to cross the blood-brain barrier, and hence they are used. In a child you're suspecting meningitis, a good combination to start would be ampicillin plus cefotaxime or meropenem. The drugs naturally have to be adjusted on the basis of a particular NICU protocol and sensitivity patterns like we've discussed. Now, what are the dosage guidelines? These are approximate dosages range. Ampicillin is started at a dose of 50 to 100 mg per kg per dose. IV every 12 hours. So BD dose of around 50 to 100 mg per kg. So you can start it at around 70-75 also. That is also a rational dose. Or you could also start it at 100 mg per kg per dose IV BD dose. Okay, so that is started. Gentamicin, the dosage being 4 to 5 mg per kg IV, and it has to be given as an OD dose. Remember, this is an aminoglycosides, more chances of causing nephrotoxicity, ototoxicity. So the dosage is 4 to 5 mg per kg IV, OD dose. Cefotaxime is 50 mg per kg IV. It is given 6 to 8 hourly. Vancomycin, 15 mg per kg per dose every 8 to 12 hourly. Now, if you have a baby who's at 28 weeks in the NICU and you are starting gentamicin, and you have another baby who's born at 37 weeks of gestation, so gentamicin will be given OD dose in a baby who's full term, but in a preterm baby you will give it 36 hourly. Okay, so the dosage is, the frequency is lesser in preterms. That always has to be checked. Always refer to your Harriet Lane. Monitoring and modifying therapy. Please write down the investigations that you will send in neonatal sepsis. You will send CBC, CRP, micro ESR. You can send a urine routine. You can send a CSF as well, because newborns develop a lot of brain infections when they are septic. Okay, so you cannot rule that out. And you will do the standard test, which is the blood culture. Okay, so amongst these are the investigation. In the presentation, you can see CBC, CRP, PCT, CSF, blood culture. You can add micro ESR to that. You can add a urine routine also to that to rule out urosepsis. Now, once you have the tests and the reports seem okay and the baby has improved clinically, you can definitely de-escalate. However, if the baby seems worse, you can escalate. And what is the duration? How long do you have to give antibiotics? Do you give it for 2 days and stop? No. So if there are mild cases, please continue your antibiotic for at least 7 days. 7 to 10 days is the range in mild cases. And in a severe late onset sepsis or meningitis, continue it for 14 to 21 days. 21 days antibiotic is mandatory in meningitis. And what do you give? We just discussed. We give meningitis, cefotaxime or meropenem. So meropenem is given. And what dosage do you give meropenem in a meningitic child? It is higher. You start at 40 mg per kg per dose. Okay. Now, what is the OPD IPD relevance of starting antibiotics in neonatal sepsis? In IPD or NICU, you start antibiotics immediately after cultures and you do not delay therapy. Do you start antibiotics before sending the culture? No. Take your culture first and then immediately start antibiotics, this exactly is the meaning of empiric, right? Then you monitor them for renal function, especially with aminoglycosides, hearing, to rule out ototoxicity. And in OPD, you refer immediately. You admit them to the NICU. There is no OPD treatment for neonatal sepsis. A neonatal sepsis gets bad in no time and you will not realize. So, the whole treatment of neonatal sepsis is antibiotic and timely antibiotic. Now, summarizing. Neonatal is a medical emergency. Please understand, empiric antibiotics should be started early based on guidelines. Choose regimens based on age and your hospital protocol. Modify based on culture reports and clinical status. Okay, here in the picture you can see all the organ systems that are involved in neonatal sepsis. How blood vessels which are carrying infections will cause infection throughout the body of the neonate, right? So something to be taken very, very seriously. And the red flag signs I'll discuss again: being poor feeding, lethargy, baby sleeping all day, not asking for feeds, passing less urine, appears cool, The peripheries are cool, they are clammy. Signs to watch out for. And fever, definitely in slightly older newborns. Yes. This is all. Thank you, students.